Okay, we're going to go to the discussion session, and we've put together some questions for the panel members. So everybody, please feel free to give your opinion. We want to hear both from the human and the animal side relating to diagnostics. So first, we're just going to talk a little bit about diagnostics in general, and then we'll focus on diagnostics during a pandemic crisis. So the first question we have is, how do we maximize our ability to use diagnostics to drive treatment decisions? And when I think about that, one of the key things I think about is speed, right? If we have a diagnostic that takes 3 or 4 days to get a result back, we've already made treatment decisions. We've maybe already started patients on broad spectrum therapy. So what do we need to be able to really make those critical decisions early on?
So I think the interest in microbiology laboratories and providing faster results is intense. And the technology to do so, I think, is coming, developed to a point where this will be realized. To really make the most of the diagnostics, we need to note that they impact on patient care. Mm-hmm. And when I talk to laboratories about producing a faster antimicrobial susceptibility result, the first thing they say is, we'd have to restructure our entire pharmacy team. We have to change when we go to see patients and when we make these therapy decisions in order to make the most of this. And I think that's the question that needs to be asked, is how do we make sure that what happens in the laboratory translates into better patient care, and what needs to be done in the hospital to let that happen?
Okay, thank you.
I can just add from the clinical as well as the laboratory perspective. I mean, what Jean is saying, I mean, to me, it's the point of care. We need it in the hospitals. We need it in our clinics. That we need those diagnostics rapidly. And certainly in the case of the point I was making about fungal diseases as well as bacterial, but certainly fungal, we're just often not diagnosing them until many days later, if not at all. And so we're throwing empiric, either antibacterials and antifungals at our patients that many times they don't need, or maybe they do need, but it's often very late because we haven't been able to make a diagnosis. And in fact, there's actually pretty good data to show that if you could rapidly diagnose a fungal infection, you would stop a lot of misuse and overuse of antibacterials, because these patients are often getting the antibacterials and they don't need them. So there was a test, or there is a test out there that actually can rapidly diagnose Candida in blood. But I think, as Jean points out, these are obviously challenging tests for microbiology labs actually to take on. It requires a big piece of equipment that they don't have. But at least the technology is there, and the ideas are there to make this happen. But I feel strongly that, especially in this sort of scenario where we're dealing with a pandemic, the ARLN system that we've developed at CDC is fantastic for sort of putting your finger in the pond of what is happening. But in terms of actually dealing with patient care, we're going to need it at the point where that care is being instituted.
Thank you. Michael? You have?
Good. This Michael?
Yeah.
All right, thank you.
That Michael.
Great. I think one of the big things we need to develop is continue not only the diagnostic testing, but our interpretive criteria on the veterinary side. In this example, we have respiratory pathogens in swine. We have quite a few available, but at the same time, when being helped to interpret those, the tetracycline breakpoints we have were developed based off of PKPD and wild type, non-wild type distributions with no clinical support for an injectable. And I'm not sure how many are aware that those don't apply at all to water or feed applications, but yet they seem to be used across those seamlessly. And so I'm going to slip in two slightly different questions here to the panel. One for Dr. Main. If we were to ask you to suddenly next week take in all the possible cases you could into your microbiology laboratory, what would be your surge capacity?
It's a good question. The phenotypic susceptibility testing that we do today, you would say is not grossly scalable, right? Meaning it's 196 well plate to be read per isolate per case, okay? And the plastics and throughput of that is certainly not, I mean, it's apples and oranges as it would compare to, conventional screening testing for molecular. And to Mike's point is there's certainly an opportunity for significant better understanding of use case driven veterinary case points or breakpoints, right? More research to be done in that area. And the other thing that is, in part of the reason that we don't do a lot of, say, molecular gene specific targeted testing for AMR in the conventional use aspects is like the ability to interpret those to clinical relevance, and which is then essentially defaults to the conventional phenotypic methods that are being used to infer treatment.
I wanted to follow up then with Dr. Chiller, a question on susceptibility testing for antifungals. On bacterial isolates, we have PKPD data to go back to. Does that exist for antifungals? And how much further behind bacterial susceptibility testing are we for antifungal?
Yeah, thanks, Mike. There's certainly PKPD for antifungal medicines. I think what we lack is just what you just actually outlined for many of our MICs, and that is outcome data, clinical outcome data, actually, to show that where our breakpoints are. So we often end up using epidemiological cutoff values, ECVs, for our breakpoints. Some drugs we have decent ones for some of the more common infections like Candida, but when you start getting into molds and other fungal infections, you just don't have the clinical outcomes. But we have pretty good PKPD for most of these drugs as they're coming out in both animals and in humans. But we also, like you're mentioning, lack those clinical outcomes.
Okay. Paul?
All right, thanks. Just towards this comment or this question about maximizing our ability to use diagnostics, I think another thing that needs to be considered there, and this is certainly a challenge on the veterinary side, and I think also on the human side, perhaps maybe not quite as much on the human side, but I heard it, and I forget who exactly said it last week at the World AMR Congress, but I thought they put it pretty well, that from a behavior standpoint, it's hard to get clinicians to do a $50 test for $5 antibiotics. And so as we look at maximizing our diagnostic challenges, I think figuring out how do we, kind of decouple those costs or something along those lines that, at least on the veterinary side, take away that, a dog with a urinary tract infection, now I need to run a $250 AST test with no insurance on to treat with potentially $5 to $10 worth of antibiotics. That's a hard conversation to get even owners or caretakers to buy into. Similar issues occur on the human side, I think, as well. So,
Thank you. Ramanan?
Thank you. Excellent talks. So this is really a question for the lab networks, the NHL, and for the on the animal side. So how frequently is there testing for animals that may be on I understand that pigs, for instance, travel across borders for processing to Canada and Mexico and so forth. Is there a mechanism by which diagnostics are actually used on either in a lot sense or in an individual animal sense? And does the detection of, say, a multi-drug resistant pathogen, would that prevent that set of animals from crossing a border? How much do these actually inform the geographical movement of animals? Are there any requirements today for any sort of testing that dictates whether animals can move or not?
Right. There are can be pathogen-specific related requirements that to allow movement of animals interstate, there would currently not be antimicrobial susceptibility-based testing inferences on such animal movement. Essentially, the antimicrobial susceptibility testing that's done and those results and so on are essentially being used to inform clinical treatment.
Thank you. Carla?
Thank you. Great discussion. Dr. Luakano mentioned emergency management and establishment of an ICS. So from the scenario standpoint, in an emergency management situation, what rapid diagnostics are included or available in either the veterinary stockpile or the national strategic stockpile or other surge capacities to help mitigate an outbreak? So I guess it's a public health / animal health standpoint.
So Chris, do you want to speak to that, or I can?
Yeah, I can jump in, Roger. Thanks. So the National Veterinary Stockpile stockpiles primarily materials for field use, not so much for the diagnostic laboratory capacity, but we are making a little bit of headway in talking them into doing some of that for us, especially for kits that don't need cold chain and would be able to be utilized prior to expiration. We leave it to the laboratories to maintain a local capacity for sure, sustainable capacity. It is one of our priorities now. The non-program office works with our vendors, specifically Thermo Fisher, Tetracore, IDEX, and we're currently working through options of how they would help us maintain some sustainable availability to reagents, test kits, plastics, et cetera, that then the laboratories would be able to utilize in the face of an outbreak. Some of that is just working through the logistics of how we might set up a rolling inventory where they could pull from that inventory to fill orders, but based on a certain, price per reaction or whatnot, they would maintain a certain level of availability for the network laboratories to utilize. But great question. It is definitely one of our priorities. Thank you.
And one comment I would just add to Christy's comments would be is in broad strokes, I think this audience can appreciate is the scalability of high throughput PCR testing is generally very good. I mean that sort of technologies, and so the labs are built for that, especially in the post-COVID era. Supply chains for such reagents and so on have improved over the course of time. But the susceptibility testing is not. That's a very different animal. It's one vendor. It's 196 well per plate, and it's not fast with the current technologies that we're using.
Thank you. Are there similar capabilities in the human health standpoint for strategic stockpile? Well, I don't know if it's Dr. Patel.
I mean, I guess I actually can't comment. I don't know, Michael, you might be able to comment better. We don't have the stockpile anymore at CDC, so I'm not sure what's in it.
No, it was moved out of CDC into Asper, sorry.
Right. So I think faster technologies, like I mentioned, will exist. And I think using those to populate a stockpile, can be done, but that would require significant collaboration between the private and government sectors.
Okay. Michael Craig?
Thanks. Wanted to have the panel comment. I think all the presentations were great. I think they appropriately focused more on the U.S. domestic side. But how applicable are some of these issues, or I guess what are the more unique challenges to diagnostics issues for low to middle income countries, lower resource environments, and what do you see as some of the dimensions of this scenario for other countries?
Well, I can see our company collaborates with Medicine Sans Frontiers to ensure that there is accurate susceptibility testing in low to middle income countries. That has been, I think, a very fruitful collaboration. And I have been impressed with how Medicine Sans Frontiers really helped to make sure this was a very easy, usable test for any laboratory to implement. So I think that the ability to expand something like susceptibility testing, which is normally thought of as fairly complex, into an easy to use test to be able to expand diagnostics throughout the world, it's definitely achievable.
Okay, thank you. Just to comment on that, it's not their inability to do it, it's the cost of the testing. And that's what we found at bioMérieux in supporting a lot of countries in Africa and low to middle income countries globally, that, we go in, we train, we teach them how to be good laboratorians, but it's the daily economic expenses of buying the tests, getting them there, transporting them under specific conditions. So I think that is pretty much one of the major hurdles that we face also in dealing with these countries. Okay, Marty?
Thank you for the panelists for a very educational session. I wanted to ask Jean Patel a question. I was very impressed by the capabilities of Beckman, which I guess shouldn't be a surprise, but still substantial. As you point out, and as Paul pointed out, a lot of the problems with diagnosis are the cost issues, that the kind of the reimbursement model is just broken. And as you point out, the support from BARDA is very useful for developing things. So my question is, when you showed a timeline for the development of a new test, it was up to 2.5 years. Now, people did a lot better than that for COVID. And so the question is, what could you do in an emergent situation if there was, in the kind of scenario that we're talking about, where there's a newly resistant organism, to develop something quickly?
Yeah. So probably the two types of testing I described that take the longest time to develop are antimicrobial susceptibility tests, phenotypic tests, and for a new drug or for an existing drug, that means that companies have experience with this drug, they kind of know how to handle it, and things go a little bit faster. To speed that up, we would need a faster pathway to clearance. I think susceptibility testing is super complex. Think of a 96-well plate as a really highly plex test. Every single dilution is its own assay. And when you're testing it against, any gram-negative pathogen that might show up in a clinical microbiology laboratory, that is a lot of development and clinical trial work. So we would need a faster pathway. And in a pandemic, you could potentially target what that test would need to deliver. For a new drug, it just takes a long time because there's a lot to learn about that new drug and how to handle it, especially in a diagnostic assay. Right now, there is a pathway to co-development. So we do have, FDA has a co-development pathway for new antimicrobials so that they can get on AST devices faster than they have in the past. And our aim is to get the most important drugs, on a commercial device at the time that the drug is approved for use. This is a very useful pathway. It gives us access to the drug while it's still early in development. We are able to work with the pharmaceutical companies on how to develop that drug. We learn as they learn about the drug moving forward. And I think that is something that helps us respond to antimicrobial resistance much faster.
Can I just add, if it's not a drug related, but following a new emerging AR gene or a molecular component, it is one thing that we've been able to do in New York with our regulatory role is quickly develop laboratory developed tests on the PCR side. And this really greatly helped us in the COVID pandemic, but it could also help us with the new emerging AR secondary scenario like we're talking about here. And also these new methods, next generation sequencing. So we're able to do something like a multi-drug resistant TB in a week now with some molecular tests that we're able to validate clinically that might take months to get that same sort of result. So there's a lot of technology that on the molecular side that may speed up if that regulatory role is allowed in the jurisdiction.
Okay. Joni?
Thank you. So, before lunch, we talked about surveillance. And now, after lunch, we're talking about diagnostics as if they're not related. They are inextricably related. You can't do surveillance unless you know about cases. And we're talking about many innovations for diagnostics, for point of care, for quick, for all kinds of ways that could bypass us epidemiologists, and we won't be able to count up the cases. So this for the panel or for anyone who has thought about this problem, how do we maintain our surveillance systems while if our diagnostics make these leaps into some of the innovations we've talked about? And you can only think back to COVID to know that, we've completely lost track of how many cases of COVID we have in this country. It's estimated that we have at least 10 times more than we know about, but we don't know what we don't know. So has anyone thought about this?
Hi, this is Christina. I can jump in for the surveillance piece of the NALM. I think my talk focused more on surveillance than diagnostics, and I did feel a little bad about that because we were in the diagnostics session, but I had the exact same thought. You really can't decouple surveillance from diagnostics. On the NALM side, for what we do for these high consequence diseases in animals, including AMR associated results too, we really have to worry about what our trade partners see us doing and identifying in the US. So we focus on standardization. So taking these big leaps in diagnostic assay methodologies is it's a little concerning for us because we have to make sure that our trade partners are confident in whatever testing we're doing. So we have to have validated tests that are proven and that we have the confidence in those results. So again, changing from our gold standard to something brand new and shiny, even though it's quick, does give us some heartburn. So we would have to do that relatively slowly. On the COVID side, things ramped up on the human side, and I think there's a lot of lessons learned that we could take to the veterinary side of things, but I don't think we would be taking those leaps and bounds to the same extent if our trade partners push back, because if we lose our trade shuts down, it can really destroy our animal agriculture, and that is our mission, is to maintain animal agriculture in the U.S. So at least on the federal side, we would not be able to take those leaps and bounds quite as quickly, I think, as we could on the private side or on the human side. Over.
Jean?
So if you think about the NHSN AUR module that was described earlier today, the resistance module is a surveillance system that is based upon laboratory test results. And so that is a way of capturing data from good diagnostics are implemented in hospital laboratories for surveillance. And you really want those diagnostics to be good because you want your surveillance to be robust. The WHO surveillance approach also collects data from hospitals. So just, collecting those data are a very strong way of performing surveillance. And I'm just going to say this because I was involved in the AR lab network buildup, but having that capacity helps to fill in the gaps. That's the kind of testing that a hospital might not be able to do, but you still need for a public health response. So being able to get that additional testing is super important.
And I'll just add that I think obviously I'm a fan of surveillance. I mean, that's what I do every day. So, but I think that, as I think Jean just mentioned, we need to capture that at the clinical lab. I mean, we're missing COVID diagnoses partially because people are doing it at home and they're not reporting it, et cetera. But we really need to go after lab data that's being registered every day in our clinical labs and be able to do surveillance on that data. And I think, as you heard, NHSN is trying to do that now more, but we still need to do a lot more of that. That's where we're going to capture it, especially in this kind of scenario where it's just happening rapidly. We have lots of patients going into hospitals. We can't rely on sort of other types of surveillance systems. We got to mine that data directly from the clinical labs where it's being diagnosed.
This is Joanna. I just wanted to ask, could our CDC colleagues please clarify what are the surveillance programs that are going to hurt once the emergency declaration ceases and those that have been supported by the COVID supplemental fund?
So I can speak to that. I think we're at a place that it's not going to change, at least for the AR data that we're collecting. That's what I would focus on for the scenario. The emergency declaration related to COVID is not going to change that. It will change the COVID reporting for that data. The supplemental funding, however, as was talked about, is currently supporting expansion of AR lab networks. So, for example, testing that was at first rolled out to just 7 regional labs has now been extended to many more states, dozens more states. So, for example, the colonization screening that had less availability is now more freely available, and a lot of states are adapting their programs and taking it up. The state response tied to that, also tied to the supplemental. The new system, the National Wastewater Surveillance System, is wholly funded by supplemental funding right now. So unless there are sustainable resources, it will go away. The expansion of NHSN to 38,000 facilities, including all nursing homes, is also supported by supplemental right now. So essentially, COVID leveraged us in very significant ways and expanded our bases in very significant ways, which has been positive. But we need to underline that we are leveraged, and if we don't get sustainable resources for those pieces, they will revert back, and we will have to essentially go backwards in time and reduce a lot of those programs that have already made significant gains.
Just like to make a comment on what was said regarding point of care testing and at-home testing. So, we screen the hospitalized patient population. We use them for surveillance, but they're very unique. They're not the general public. They're the sicker patients that may end up in the ED or being hospitalized. And as we move towards home testing, right, we do it ourselves for our COVID when we get it, and so there is no surveillance. So how do we deal with the onset of something that might be new? Well, maybe if it's new, you're not going to immediately have home testing, but even an influenza test that's going to be, you could buy it over the counter in Walgreens next year. How do we actually manage these outbreaks and whatever when we're not going to have reporting? So how do our surveillance systems need to adapt to capture at least part of this information? CDC want to comment or state public health?
I mean, I think it's a great question. This has been one that during the pandemic especially challenged a lot of our STD clinics, right? Because STD clinics closed. And so where were people getting STD tests? Well, a lot of people weren't getting STD tests. And then there's a question of, well, can they get them in the home? And then if they get them in the home, what's to be done? How are we to know what happened? What can be done with contact tracing, et cetera? So we're like the STD side is in fact piloting ideas for, how they could potentially come up with alternatives if faced in this. And I think we all need to adjust to this new normal. I don't have a great answer for you because I think this is one that we're going to struggle with and have to figure out what some of those issues are. I think, one thing that we would point to is that for severe cases of any disease, we are likely to see that in a hospital, and it is likely to fall under surveillance. And so the high acuity cases we are likely to capture, and those are, I think, for especially our AR infections, are going to be probably the most meaningful ones. But I think it is a very valid concern of, how do we, consider this and adapt to this.
Okay. Tim?
I just wanted to follow up on your question. And outside of the United States, in some places, there were actually very clear incentives that meant that people doing home testing would report in their results to public health surveillance. In the first instance, it was it gave people the opportunity for treatment. So it was a rule-in kind of test. And then what we saw was a shift to a rule out, that people would take a test so that they could prove they were COVID-free, so that they could gain access to participating in particular activities. Now, I wouldn't want to suggest we want to create a world where everything requires you to be tested all the time for things in that way. But nonetheless, that demonstrated that it is possible to create a system of incentives that mean that the data can be captured into public health systems as well. I do also want to raise a question. When we are looking at these situations and the necessary linkage between diagnosis and surveillance, we focus a lot on the technologies and the platforms. And I wonder if that's a little bit of a distraction where we're losing sight of the fact that what we care about is the information and what decisions can be informed by that information. We're actually awash in data as it is. Tom's point, I think, is a very, very apt one. There's a tremendous amount of data already generated in healthcare systems that probably could be harvested and utilized to a better extent. Do we have a clear articulation of the information needs and the decisions that would be informed so that we can focus the attention more on the creation of the information to inform those decisions and maybe worry a little bit less about specific technologies? The technologies will follow. I'm thrilled to hear Jean saying how quickly diagnostic tools can be developed. That's pretty rapid by any sense. But it does seem that we still get stuck on focusing on the technologies rather than supporting the decisions. Thank you.
Thank you. Virginia?
Maybe this isn't the right question to ask, but or maybe it's not a question. But as we're talking about, this is a little bit along what you were just saying. What is the federal role in the actual appropriate application of the diagnostic tests as opposed to developing new tests? So how do clinicians actually learn how to appropriately use the information? So I'm just curious about that, thoughts on that.
Well, I can tell you from my own experience, having run diagnostic labs for 40 years, that is such a critical piece that there is maybe not always specifically with a new technology or a new test that comes out. There's skepticism, there's unsurety about the result, and there's not a trusting of the results. So, for example, and for good reason in certain patient populations. So if you have someone coming in with influenza and you're worried about a secondary bacterial infection, if you don't have that concomitant diagnostics, yeah, they may give them oseltamivir, but they're still going to give them an antibiotic if they suspect they're coming in with a, community-acquired pneumonia or whatever. So I think we're kind of in a standstill about that. Maybe not so much in pediatrics. Our pediatric partners are extremely good in doing that, but in the adult setting, we see that, particularly in the outpatient setting, they'll just say, oh, no, I'm still giving them an antibiotic. I don't care what the test says. So I think where we lack in the diagnostic is that definitive test that's going to tell you which that's one of the holy grails, that it is just viral or it is viral and bacterial. And maybe, yes, I do need to give an antibiotic. We still may not know could be simply as amoxicillin. It doesn't have to be something a lot more broad spectrum. But until we have that perfect combination, I see we're still in a diagnostic dilemma that will follow us, throughout the next pandemic that we have. So, okay. Armando?
So as a patient advocate, I tend to see things a little bit different than the rest of you. And that's not a good thing or a bad thing. It's just different. And when I hear about, I constantly wonder why I was given home testing for COVID. Because it gives me the results immediately, right? Sometimes a false positive, sometimes a false negative. But regardless, I get the results within 10, 15 minutes. Why would I want to do that when instead I should get the result of a code that I have to send in to get the result? That code will tell you, the CDC, whether I had COVID or not. Now you can keep track. It's not complicated. We have the technology, but it's a code rather than me seeing the results immediately. I have to wait an extra 2 minutes. It seems simple to me from the patient perspective. It doesn't seem that complicated, but maybe it is. It's something that I don't understand. And I think it would be very easy to implement. HBO does it. Paramount Plus does it. You have to sign in with a code, right? It's the same thing. It's not complicated. So maybe you can shine the light on that. I don't.
Ramanan?
Thanks. I was just going to build on what Tim has mentioned, which is this applies, as Jenny said, both to surveillance and to diagnostics, because both are a capture of information. And I do agree that we need to focus on why we're doing what we're doing. It's not so much the technology. That's a secondary question. The first question is really, if we're calling for investments in surveillance or calling for investments in diagnostics, what is the federal interest in doing either of these? And typically it's because there's information that's valuable for a public purpose. That's really why it is. The diagnostics are important because diagnostics have both a private information value, which is about the patient getting treated, and there's a public information value, which is they feed into surveillance, which tells the rest of the world what's going on with them. And to the extent that they have that public information value, then it's worth the federal government being involved to be able to say, I want that bit of information out of it, and I'm willing to pay for it. And surveillance systems are just the build up on that. They're sort of the aggregation of that public process. I think there's work that remains ahead of us in order to determine what the actual economic value of that surveillance is. Because it's surveillance just to say I want surveillance information is not really meaningful. It's a question of what you're going to do with it. And I think we need to invest in surveillance to the extent that it provides value, whether in informing the progress of the next pandemic or, in terms of formulating appropriate treatment guidelines, or I think we need to formulate that set of questions of what we want that information for, and then work backwards from there to say what surveillance or diagnostic do we want from there. And I think we need to tee up those questions in that order rather than put it in the order that I suppose we've done. The second part of this is that we don't want this report, I suppose, to be a recap of, we've talked about surveillance and diagnostics, for every year of PACCARB, every year. What makes this different? This year is different just because there's something which is potentially faster moving, potentially something which, is not taken care of by surveillance systems that we have at routine times. So what we really need to explain is the delta between what we have and what we need to have in order to be able to respond to a new outbreak. And, I'd love to hear some more thoughts on that. What is that delta? It's just not just the normal. It's the unusual that we're being asked to talk about.
Thank you. I'm actually commenting on a question from a couple back, but this is about the federal interest in the role of diagnostics. And I think you brought up some really important questions that I think the federal government has some interest in, which is, how do you apply a test in the best way? And that can vary based on the test and the patient population, as well as the cost. And I think, very simply, we need research on this. I can take the example of procalcitonin. Some hospitals, it leads to increased antibiotic use. In some hospitals, it ends up, resulting in lower antibiotic use. So, for instance, ARC has funding for research that looks for optimal clinical integration of diagnostics. And I know there are other agencies that are interested in it as well.
Thank you. Jason?
Melissa, thank you for saying that, because I was thinking similarly. Diagnostic stewardship has become a thing, and while I think in this scenario that we've discussed, molecular testing will be essential when we're looking at resistant pathogens and trying to identify them soon. However, in doing respiratory testing, not all those things that you see there are actually necessary to be treated, and therefore we end up exacerbating our problem of AMR because we're now using the bazookas to treat something that doesn't need a bazooka. And I think, as you mentioned, procalcitonin is another CRP that has become just another test that just drives up, healthcare costs unnecessarily, to the point that I think in pediatrics it shouldn't be used, but that's a different story. So thank you.
Okay. Paige?
I think mine was in response to some things that were said earlier. So I agree. Point of care testing is absolutely critical in hospital and clinical situations. I agree that home testing, as COVID showed, demonstrated a lot of value. And certainly being able to tell virus versus bacteria, no question. But I don't think we need all of those all the time, right? So I don't need a home test to figure out if I have a colonization with some fungal thing, because if I'm that sick, I'll be at the hospital, and hopefully they can figure that out. But I think the other thing that comes into play, it was interesting with COVID. I don't know how many varieties of home tests I had between my children and my family. And one of them had, I forget which manufacturer it was, but you actually had to use an app. So I wondered myself at the time how much more that cost than the ones that didn't have that, and to develop. And then I had to have a phone, which means I had to be able to have that, right? So it's a cost, it's an equity issue. And then even if I weren't in the Department of Defense, I just listened to my neighbors, the whole privacy concern about having this go out there. So while I do agree there's value in having these systems that let us, show these home tests, there's equity and cost, and then there's privacy that has to be considered. So anyway, I'll stop there. That was from earlier.
Elaine?
Well, I think it's sort of been said, but we're jumping around. And so I did not want to lose Armando's idea, because it's a really interesting idea. And then Ramanan asked a couple of questions we haven't gotten to either, but I just wanted to get back to that one. And I think part of it is what Paige said is HIPAA. But it would be easy to have somebody sign an okay to let their data be, and it is an interesting question, and probably none of us have the expertise to answer, but why couldn't the results of a home test also wouldn't even have to wait. It could be simultaneous. Go to an appropriate database of some sort. And it's an innovative idea, and one we don't want to lose.
Elaine, in regards to that, though, and I agree with what Paige had said, I think there will be an issue of inequities, right? Not everybody will have a cell phone. Not everybody may have internet service. I mean, in today's world, but there's still people that don't. And then it becomes dependent upon getting a test result that you have access to this, when we've tried really hard to make testing available on an equitable basis, which was really tough in the beginning of COVID, right? It was only the big university hospitals that could do homebrew tests, and the community hospitals were stuck with no testing. So I think those are some considerations that I would be, I want it to be reported. We want to track it, but
I actually do think that home tests, for example, our tests are offered free in New York. They're not offered everywhere free, but the inequities are real and they're terrible, but that shouldn't stop us from doing nothing. To say, well, if not everybody can do it, then nobody can do it.
But you avoid inequity by just taking, for people that don't have cell phones or internet, they take it to the closest clinic that we can work with them and they'll give them the results, but at least it gets reported.
Okay. Let's see, who's next? Stephanie Black. Last question.
Hi, yeah. So Stephanie Black, Chicago Department of Public Health, and I just wanted to chime in because you asked kind of what state and locals were doing with the home test results, and you're right, we were not getting those, and I think to a certain extent, what we needed to rely on as the pandemic moved forward was the more severe cases, as Dr. Craig alluded to, that was really what CDC changed to focus on and what health departments needed to focus energy on. But there was definitely a need for that point of care at home so people could, not send their kids to school, or in congregate settings so we could, isolate people so nursing homes could do that. So, whether that technology could be used going forward from a federal level to make that QR code, available, not only to the end user, the person who purchased the test, but health departments, if there were, at the beginning of another situation where we were tracking all cases and needed to do contact tracing, that just to a certain extent couldn't work with COVID ultimately. And then I also just wanted to raise one other issue to what Ramanan was saying about kind of the unique aspects of a diagnostic test. I just wanted to raise the issue of the specimen type that could be submitted, that there's some regulatory reasons, that you can't. So for monkeypox, we particularly found, there was a lot of interest in swabbing anal lesions potentially to look for asymptomatic transmission. And there were limitations that we needed to focus on only collecting specimens from lesions. And so looking for some flexibility in being able to collect certain sample types. I know that the data needs to be collected to make sure that information is reliable, but that data has to be collected.
Thank you. Okay, we just want to shift topics quickly because there's an important one we'd like to finish up with. So if we think about how the federal government could support the development of AMR diagnostics, where do we think we have the greatest gap? What AMR diagnostic would we want to put on the top list, and in what order of, go for the holy grail, whatever we want. But, where do we think is the biggest gap in our current diagnostics for AMR? Does it relate to speed? Does it relate to technology? Does it relate to only certain labs can do quick rapid sequencing for genetic markers? How do we get that into the hands of a normal hospital laboratory that would have to be doing? They're on the forefront, right? They're the ones that are getting the patients that have these.
Can I just add one thing that there was a nice test that was available that we had a private-public partnership with a company called OpGen, who had developed a panel of antimicrobial resistance genes as a single test, but they did it in a way with accessory genes so that you could actually get a fingerprint of the organism at the same time within a couple hours in the hospital setting, so that could be utilized to identify transmission very quickly, along with getting the AMR gene in terms of treatment. Unfortunately, they moved forward with FDA clearance to only include a certain subset of the genes that could be utilized for treatment, and they left out the infection control piece that we really found utility in. So something like that, if it were to be, the FDA piece was not suitable for the company to move forward with it for the infection control, but that would have been great. Point of care, infection control assay.
Okay, David?
Thanks, Christine. I go back a couple of years to when the WHO published a list of bacteria for which new antibiotics are urgently needed. I wonder if the PACCARB could twist that a little bit and come up with a priority pathogen list of where we need new therapeutics, diagnostics, and so forth, because if we have a huge scientific workforce out there that we could mobilize if we put out a list of these are the diagnostics that are urgently needed in both animal health and human health. And that the federal government could help incentivize basic science and advanced research and development. So I just throw that out there as a potential idea.
Libby?
Oh, sorry. I think this was up from a previous comment, but I'll answer your question anyways. I would say along with diagnostics, we need federal incentives to put diagnosticians where our patients are. I have small community hospitals in my network at Duke who have every machine in the book sitting under plastic in a laboratory because there's no one to come in and turn it on and run tests for the patients. And so with the tests, we need people to run the test at where the patients are, because sending it away, we lose those patients, especially when we talk about, it's one thing in a hospitalized patient, but if it's an STD, we never get them back. And so the quiet, dark, unused machines are really distressing us, as well as the need for some new diagnostics around our resistant pathogens.
Who's next? Oh, Tim?
I think that we have some significant blind spots. So what I would like to see is that we would expand priorities to focus on community AMR and not so solely focus on hospitalized patients in this setting. And also looking across to the One Health dimensions, I think that there are blind spots there, and understanding AMR as relates to animals in the environment, and really to be able to better understand the risks associated with transmission chains there.
Oh, Dr. Patel, sorry.
Yeah, I think that if I was to think about a wish list, it's actually very simple and something that would be useful on an international scale in a pandemic, out of a pandemic, would be along the lines of, again, trying to distinguish between a viral sepsis and a bacterial sepsis. And many people have worked on this, and procalcitonin tries to get at this, but that would help slow the AMR pandemic significantly, but would also help in our mock scenario, would have helped in COVID. So I think on every steward's wish list, that would be number one.
Yep. Excellent point. Did I miss anybody? Dr. Fernandez? Did you have a question? Oh.
I was answering actually Ramanand's point. That's why I put it down since you moved on. But I thought this report was on not what we have now and what we are already working on, but what we have learned from COVID and what we need so that we prevent or don't go into the same dark hole on the next pandemic. So how do we prevent all the problems we've had at this pandemic? So that's what we've got to focus on this report, because many of the diagnostic tests are being repeated or being developed now. But speed, of course, is essential. So there are things which are missing. I did hear about the community. So there are points which have been raised, which we need to put in action now, because when a pandemic happens, we can't do it at that time. We also need the expertise to be able to do it. We need the infrastructure. We need the data. We need the epidemiology. We need all that. So we've got to have it going on every day instead of putting it in place at the next pandemic.
Yeah. Michael, Craig?
I think, we could come up with a long list of things, but I think some of the points that the panel made, especially Jean, I think that it's if you build it, they will come is not good enough, right? Just making a diagnostic, just making an antibiotic, just making a vaccine and assuming people will use it and use it well we need to get out of that fallacy, right? We have to educate people, and we need to integrate it into our practice so that it can be effectively leveraged and change what we want it to change. And I think that's something that I think we continually underestimate. We still see with flu tests, rapid flu tests, doctors use all the time. The number one thing that's prescribed after that flu test is still an antibiotic, more than an antiviral. We have the flu test, but it's still leading to a bad practice. It has not been trusted. It's not been incorporated to change the thing we wanted it to change. And I think we really need to figure out how we can come to terms with that and better address that, and not just assume if we get it to market, then the market will work, because that's not the case.
Thank you. And one last topic that we'd like to briefly discuss is How do we maintain our AMR diagnostic capability and capacity during prioritization of viral diagnosis? Okay, so and let's take a look at COVID, right? Everybody frantically panicked to make COVID tests. Okay, that was necessary. We really needed that. But if something else emerges during the course of that relating to AMR, how do we take those resources and make them equitable for the other consequences that we may see?
Sorry. Part of the problem is it costs a lot of money and time to develop a new test. So, if you look at other areas, like if you look at vaccines, we're allowing the approval of something without a human testing, right? With the booster shots. We're getting an animal test and saying, okay, we can approve it because it's the same technology. So if you use the same technology to develop a new diagnostic quickly, so maybe it can be used for something routine until that special pathogen X comes along. And if you can adapt it quickly and get it approved, you would save a lot of money and it would have a lot of interest in doing that, in having what we call platform technology to be able to do it. Otherwise, for every single new gene, new thing, you have to get it approved. It costs a lot of money and time. And the diagnostic companies are not doing well enough to do that. So establishment of diagnostic platform technology, which can be rapidly adapted without having to run clinical trials, will be very important.
So there has to be something done about the workforce. Just trying to implement a new test in the laboratory is so hard. One, everything has to be automated and it has to be so simple. And those two characteristics speak to how the microbiology workforce has been decimated. And it was in trouble before the pandemic. It's in super amounts of trouble post-pandemic. And if we're going to survive another infectious disease pandemic, something's got to be done there.
I don't have an answer for this, but I have a comment based upon what I've heard. If there were another pandemic, I know we've talked a lot about the COVID, but our scenario is both an animal and a human outbreak. And I know with our previous outbreak, many of the veterinary resources are going to get reallocated to public health. So that's just, again, I don't have an answer, but something to think about as we go forward with this scenario is what is our surge capacity and how do we address both animal and human health when obviously the human health is going to take priority.
Good. Okay. Do we have any other final comments or questions? If not, we're going to take a 15-minute break, right? And then we'll come back at 3:25. Okay. I'd like to thank our, 3:20. Like to thank our panelists. Great job. Thank you, everybody.
Produced by the U.S. Department of Health and Human Services.